that the 111th Congress is planning to put something through no matter what when they come back from this recess?
Well, I certainly hope we can reach some consensus on a health care bill and pass it in this session. It is what practically everyone on both sides of the aisle campaigned on health care reform. We have to reach a consensus for what that means and whether or not it will be good for the country. I sent a letter out the week before the August break saying we do need to have this debate. I sent it to the leadership and the speaker, and I made myself known in the meetings with the leadership that I thought we needed a month to explain some of these provisions in the bill to our constituents, to take their input, and then to go back and work, having received that input, to improve the product. I certainly hope that before the end of the year that we have a health care bill through both the House and the Senate.
Thank you, Jay. Panelists, are there any additions to that? All right, let's move on to our next person. Constance Merrill McDonald, please start.
I am a mental health and substance abuse treatment provider, and I've recently opened up an agency and am currently very focused on issues of credentialing providers and getting on insurance plans and dealing with the general nightmare of it all, trying to figure it all out. And so as I'm listening to the various options that are being put forth, especially this option of having insurance go across state lines, and I'm thinking, how would we deal with that? Have you thought about how we're going to credential providers, especially if we're getting insurance from Connecticut and we live in New Mexico? How are providers supposed to deal with that?
It is one of the reasons why I think that hasn't been a more popular answer once you get into the details. It makes sense to me that if you get bigger pools, you can bring down prices, and so it's a very attractive idea in that sense. Where you start to run into problems is as soon as you begin to say that you're going to have nationwide insurance pools. In theory, I think if we regulated them adequately at the federal level, the way that some states do, we could have a better situation than we do now. The problem is in actually getting it done, and the fact that as soon as you start down that road, you create a whole new set of enemies, 50 governors, insurance commissioners, and accrediting organizations, and you know, that has been part of the mix of why I think that idea has not gone further yet. Paul, do you want to address that? Paul and I have known each other for a long time. We disagree, but we're not disagreeable.
The idea is to regulate across state lines, and I don't know all the details, but it could work, and it may not work ideally at the start if you do this nationally. It would actually be great if, say, New Mexico, Arizona, Colorado, Texas got into a regional situation where they came together. The big problem is mandates and some of the regulations that states put on them. If states could back off on the mandates, New Mexico, we have over 50 mandates on various types of coverage. That would be a way that especially the low income or the invincible 20-somethings would get into the insurance pool, and we would have a better result all the way around. So there's no silver bullet, I like to say, in a healthcare debate, and that is just one option that we're considering. But you know, there's some legislators here, they might want to consider getting into a pool together here with the region.
Thank you, Paul. Any other panelists wish to weigh in? Dr. Behiel.
Yes, I would just like to comment on in terms of what Constance said. In terms of credentialing across state lines, of course, most physicians are credentialed through Medicare. If they do accept Medicare across state lines, it's a national, it's a national program. However, I can't agree more that we do have to have more choice in terms of insurance and private insurances in places like New Mexico. One of the problems, if we don't have choice or we're limited to choice, then they become they become giant, and they become very selective in terms of who they want to accept. And they can exclude small practices, independent practices who might want to try to keep costs down by not accepting them into their panels, thereby actually squashing free market reforms.
Thank you, Dr. Vigil. Representative Heinrich.
I want to echo what Dr. Vigil just said, because I think he is absolutely right about this issue of once you start allowing cherry picking, where you no longer have a big insurance pool, you're always working to try and find a healthy group of people to insure because they're the lowest cost. And I think that's part of what insurance reform needs to look like. Insurance is about throwing everybody into the pool and then reducing costs for everyone and avoiding the catastrophic cost impact on one individual. We need to get back to that, because if you compare health insurance with auto insurance or homeowners insurance, those are very competitive markets. I get a letter from Geico every week trying to win my auto insurance over from from my current provider, and so as a result, they have not grown. They've grown in terms of their costs, but they've been commensurate with inflation, not twice inflation, not double digits. I think that's very important, and I do think that a lot of people don't understand this idea of a healthcare exchange, but the easiest way I can explain it is that the healthcare exchange that's in the current legislation would take the model that is currently available to all federal employees, which is basically a healthcare exchange where there's a bottom line with a minimum that an insurance company has to provide. They have to meet certain thresholds to be part of the exchange. And then in that exchange, you have many providers with different